Hello everyone, this is Bob Browner, recording a summary of kind of our lessons learned after the second year of working on these quality projects for the Department of Health and Human Services. So lessons learned so far breaks down into about six categories. I won't read them all off to you. We'll just kind of go into each one and talk about what we're seeing so far and where we'll try to change in the future. So first, one of the big things I've learned over and over again for years is that staff turnover kills quality improvement. And one of our obstacles of this project is that almost every clinic we work with has had turnover of one or more key positions, and one clinic even lost all three of these positions in the last 2 years. And so without the stability of the staff in these areas, it's very hard to continue really good quality improvement efforts. And so you'll often find that sometimes the performance has a lot back to staff stability. So I'm not sure exactly what the solution is, but part of it, of course, is some stable funding for these types of projects. And so one of our effort goals is to make this it's hopefully another 4 years of this grant funding through DHHS, and hopefully to get it to line up with other things. So, for example, a couple of the clinics, this is close enough to what they're doing with Blue Cross Blue Shield, that they have multiple streams to keep this funding and build out their quality improvement and care coordination staff. But another thing we keep finding too is just the instability, especially in the clinical side of things in the clinics, is really limiting people's effectiveness. The other thing is like the Middle Eastern proverb, you can't fatten a cow by weighing it. And it's some of the things that the measures that are put out there are more designed for weighing the cow as opposed to feeding the cow. I'm a rural kid initially, and this is me as a 15-year-old at the Cheyenne County Fair with the heifer I was showing that year. But feeding and weighing the cow is kind of one way to think of these things. Most of the measures that are defined by HRSA and Medicare and insurance companies are what I would call weighing the cow but not feeding the cow. They're often calendar year reports where they basically want you to report the end of the calendar year. So the report is basically looking at patients seen this calendar year. This is not a quality improvement report, however, because most quality improvement projects define your population much broader, and they're used as also a gaps in care report. And so gaps in care often reflect people who've not been in this calendar year. So if you're using a calendar year report, the person who needs an HPV vaccine or a colonoscopy or a mammogram is not going to be in the calendar report. That needs to be a broader population. And so when you're defining quality improvement projects, the ideal is all active patients, but that can be hard to do because you have to actively manage who is currently your patient and who's not. And some clinics don't have a good system to do that. So some will limit farther down and say all unique patients in the last 24 months, and that's our population that we'll define. Population health starts with defining your population accurately. An insurance company and governmental reports do not define the population accurately. So using that HRSA report or an ECQM, some EHRs actually define it this way as well because they're designed for billing, not patient care. And so making sure that everybody understands the difference between feeding the cow, which is a good quality improvement report on a broad population, and end of year weighing of the cow, which is the HRSA type approach, and it needs to know why these are different. The other challenge we find is the grant funder timelines versus running a clinic. All of these things are in different timelines. So, UDS and HRSA are calendar year, as are a lot of Medicaid, MCO, and open enrollment contracts. This DHHS grant mostly runs July 1 to June 30th, which is closer to Blue Cross, but now we're actually having some hiccups with the contract where, because of the ultimate source of funding is CDC grant, which runs on the federal fiscal year, none of these contracts line up. But you have to take care of your patients. They're more stable. They're yours regardless of whatever the contract says. So we need to run a clinic operation on patient care continuously. And these contracting timelines are a pain and are an obstacle to what we're trying to do. On top of that, a lot of governmental contracts actually start late. So by the time you may be months into the contract year before you even get all the final information, and things, of course, as you now know, change as you go, which is also a challenge to implement in your clinic. Uh, the other problem we run into is too many competing definitions, reports, and requirements, and this is universal across healthcare. So it's not just safety net clinics that deal with this. All private practice clinics are running into the same problems. We have Medicare shared savings, Blue Cross Blue Shield, Medicaid, all defining quality differently with different types of measures. HRSA mostly uses NQF definitions. Blue Cross and Medicaid, the insurance companies, use HEDIS definitions. Medicare shared savings, which are some of the new ACO contracts, sometimes use NQF, but not always. And then public health measures are defined somewhat differently. Added to that, you have Every Woman Matters criteria, which is kind of a hybrid sphere between all these, and their criteria don't always line up with what any of these do. And that just adds to the confusion and difficulty with clinically implementing any of these projects. And then there's, of course, clinically defined, which actually doesn't line up with any of them sometimes. What's good for patient care changes faster based on research and evidence, and these people don't always follow those, unfortunately. So an example I would say is that in our Lincoln project, our pediatric community basically set the definition of quality based on what would help them achieve their aims. And so this worked well for us. And we've been using this. We're in the second year of this project using a definition that we created ourselves to help us better take care of our patients. But now Blue Cross Blue Shield luckily has adopted HPV as one of its quality measures, but they're using a HEDIS measure, which is completely different. It limits only to patients turn 13 during the measurement year. So again, it's a weighing the cow measure, not a feeding the cow measure. This is good to see how good you're doing, but it's not a good report you'd want to run based on quality improvement. They're also limiting the definition to HPV vaccination given between the 9th and 13th birthday. So a vaccine given on 13 years, 1 month would not count. Even though it's good medical care, it doesn't meet their definition, and so you have a mismatch between the clinical definition and the HEDIS definition. And of course, both of these are actually out of date. So now the CDC does recommend that we give the vaccine at ages 11 and 12, which of course does fit better with that Blue Cross definition. The reason, of course, is that the vaccine has a better immune response at younger ages. We're also finding with our project that there's a little bit better sales pitch when given younger. At ages 9, 10, 11, parents are still a little bit in that multiple vaccination mode, and they haven't really started thinking about sexing their kid yet, so that doesn't come up in the conversation. So we're actually finding not only is one on the research showing that the vaccine is more effective, the sales pitch to parents seems to be go better at this younger age group. So over next year, we'll probably start changing our focus and definition a little bit, and of course, HEDIS measures will lag as they always do. The other problem we're running into right now, of course, is no grand plan. These things are done in isolation. Successful quality improvement initiatives really mature over 3 to 5 years, but grants and contracts are often only 1 to 3 years long, and then they're constantly evolving, often ignore local needs, change with the latest fads, buzzwords, and politics. We are trying to guide everything toward a grand plan statewide. We've started working with UNMC College of Public Health. I'm meeting regularly with Ali Khan, and we're trying to convene a multi-quality measure stakeholder group in Lincoln or in Omaha to hopefully do some statewide planning to hopefully get some of these things to start aligning better. As I've said, this isn't just a problem for safety net clinics. This is a problem for all private practice clinics as well. Everybody is facing this challenge and really wants some coherence and consistency around quality projects that are used by funders and insurance companies. So we are trying to work with those as part of what we're doing. The other thing that is getting more and more evidence behind it too is the social determinants of health, and I work quite a bit in this area. I'm actually on the National Quality Forum Standing Committee on Disparities right now, and we've had numerous meetings talking about this. Some examples that came out from some of our site visits, Charles Drew, we were at that clinic, and they happened to run their out-of-control diabetics stratified based on household size and found that more than half were from a household size of 1. And so it turns out that social isolation, lack of support, and probably even some mental health issues are probably correlated in explaining some of that uncontrolled diabetes. So it may not necessarily be that your diabetes control is bad clinical treatment. It's just that there's so many other factors that go into all this. Midtown, they also pointed out, and others have echoed this as well, you see much lower screening rates and control rates whenever there's a mental health diagnosis in place. And so a lot of us already do know that mental health affects things quite a bit. I was actually told by an ACO insurance company executive that if you basically add a mental health diagnosis to pretty much anything, whether it's heart failure or diabetes, you can multiply the cost of care by 2 to 4 times. And so mental health is probably one of the most underappreciated things here. The other thing, of course, as you all know too, there's a lot of variation. Outcomes are often determined more by insurance status. And a slide is everybody's results on colorectal cancer screening. And so what you see here, here's what everybody's reports have been over the last 4 milestones. You'll see that the one clinic that's highest happens to be a residency program clinic that has very few uninsured. And so likely this is part of the reason they're better is because they don't have as many people with no health insurance, whereas a lot of these people, it may be that there's a willingness to get the colonoscopy, but they just can't afford it. The 3 here are also all in the same community there in Lincoln, And Lincoln has some ongoing patient assistance programs so that you can get lower cost colonoscopies for people. And so the burden of lack of health insurance may be lower in Lincoln than maybe in some other communities. And so that your performance in this measure may also have some effect on the community you happen to live in, not just insurance status. I did ask Ron to run the numbers here. If everybody had this same screening rate as the residency program, 4,000 more people would have been screened for colon cancer. Many of you know that those 4,000 people, that would save quite a few lives actually to get those people screened. And what we're seeing there is partly the after effect of the fact that Nebraska has not expanded Medicaid. And so with all those uninsured, because we've not expanded Medicaid, that unfortunately people are dying. And so we may use this for policy advocacy to say, look, yes, we want to keep healthcare costs low, but without expanding Medicaid, unless there's another alternative, people in Nebraska will die because they don't have access to screening. Breast cancer screening, again, we're seeing a lot of variation. I think most of this right here, like this clinic, is basically lack of documentation. I think part of this is cleaning up the documentation. Again, this is a clinic that's had a lot of turnover, and that's been one of their challenges. Cervical cancer screening, we're seeing some people improving. This one, I think, again, was a documentation improvement, but certainly much better, which is good to see. Uh, Also, adequately controlled hypertension. Actually, this is one where I was actually pleasantly surprised. This is actually pretty competitive with national recommendations, partly probably because blood pressure control, luckily, is not as expensive. There are a lot of good blood pressure medicines that are in that full $4 generic range. We're also finding that there's been a lot of improvement by focusing on checking the blood pressure correctly. So the new guidelines really focus on making sure that we are checking the blood pressure the right way, and that is the patient should be seated, their back supported, they should have some time to rest for a little bit. And so sometimes people are checking the blood pressure too quickly and not technically correct. And if it's not technically correct, you should remeasure that. But we are seeing some improvement. That these numbers actually, I think, are pretty nice for blood pressure control. It's a very broad quality measure affecting lots of people and leading to all kinds of complications. So if we're doing better in this area, that's a good thing. Also, I'd put a plug. We only have one clinic that's doing HPV vaccination, and now with the addition of Blue Cross Blue Shield adding HPV as a quality measure and potentially Medicaid as well, I would hope that clinics will start now measuring HPV vaccination and focusing on that. This is an area where we basically are at the point now, HPV vaccination, it's been around long enough, the evidence is good enough that we could pretty much eliminate cervical cancer from Nebraska in a generation if we could get better vaccination rates. And also half of throat cancers now are HPV related, so we could eliminate half of throat cancers as well in a generation or so. So if we could get a better job with HPV vaccinations and hit that Healthy People 2020 goal of 80%, I think we could do a lot of good for the state. So next steps, Mary Jo and I are working actively to try and get these interim and long-term contracts to line up so we can have some consistency. We've heard from all of you that the changing definitions and measures and things not fitting together and coming in late after the contracts are signed, we'll do our best to work with the state to make these all line up. We'll are trying to put this in the context of other statewide initiatives, both with public health and insurers. So I regularly meet with, like I say, Ali Khan at the College of Public Health. There's also a Medicaid quality meeting that's in Lincoln that Lisa White convenes, the Medicaid director for Nebraska. And we're trying to bring in the other insurance company medical directors into this as well. And Ron will continue to work on streamlining those forms and reporting so you're not wasting your time with paperwork, but actually spending more and more of your time where it's most effective on good patient care. So if you have any questions, let me know. Hopefully this is helpful, and we'll start working on site visits for the next round soon. Thank you.